preliminaries. Welcome everyone. I'm Tony Latai, President of the Society for Functional Precision Medicine, SFPM, and welcome to our monthly seminar series. I have to say that the interest in our series it continues to be very strong, and we're now scheduled out to the nearly the end of 2023. If you have an interest in presenting, I'd say let me know as soon as possible, or let Aaron Jesser know as soon as possible, so we can discuss it and hopefully get you scheduled in. I think it's very healthy. I also think it's extremely healthy, as I'm starting to see exactly what I had hoped and predicted we would start to see, which is one after the other, like week by week by week, more and more good quality functional precision medicine papers coming out in really respected journals. This is a strategy we talked about several years ago, whether the SFPM should have its own journal. And I have been opposed to that idea because I thought we could better broadcast our ideas by publishing in the main scientific literature, so we would be talking to others rather than ourselves. And I'm cautiously optimistic that this strategy is working. I'm really impressed by the quality. Saw a couple of really nice pediatric papers out just in the last week. And I'll also say this: when you publish these things, contact me or Aaron at the SFPM and let us amplify your signal. We're very happy through social media as well as on our main website to publish links and blurbs about all the interesting research you're doing. I think it benefits us all very much to do that. So what I'd like to do now is I'm very happy to introduce today's speaker, Sigrid Skanland. I view her as one of the real original functional precision medicine people, and I've known her for several years now. She is from Norway, continuing, I don't know what the geographic reason is for it, but the real strength in the Northern European countries in functional precision medicine and oncology. Maybe someday someone can explain to me exactly why that is, but it certainly is the case. Sigrid got her PhD in 2009 with Kirsten Sandvig. She then did an EMBO fellowship with Ivan Dikic in Frankfurt. And for the last 10 years or so, she's been working with Kjetil Tasken in Norway at Oslo University. And in the last couple of years, she's established her own independent research group with a real focus on ex vivo chemosensitivity of lymphoid cancers, but particularly, as I'm no doubt we will hear today, particularly in chronic lymphocytic leukemia, CLL, which is I know a big interest of mine and of my colleague Matt Davids, who I'm happy to see here on this call. It's notable that just a couple years ago, Dr. Skanland was awarded a prestigious European Commission ERA PerMed research grant to do exactly the sorts of things that she's going to be telling us about today. So Sigrid will give her talk. As always, please either raise your hand or send me the questions in the chat. The numbers are fairly large, so I think today we should try to send the questions into the chat. And if you're around, I'll try to call on you and have you present your question. But I'll sort of moderate the questions through the chat if you could. So without further ado, Sigrid, please take it away.
Thank you so much for this kind introduction, and also for the invitation to present our work to the Society of Functional Precision Medicine. It's a real honor to me. So I'll present the work we are doing at Oslo University Hospital in Norway, and the main focus is CLL. So when we talk about the precision medicine to our friends or even our colleagues, I think the chance is pretty high that this is the things they imagine. So a defined mutation in their patient's gene that can be linked to a targeted therapy that is then used to treat the patient. But as we know, there are several approaches to precision medicine, and the common thing for these approaches is that we want to study the tumor cells of the patient and to find certain characteristics that can predict which therapies are effective at killing the tumor cell. And our approach is functional precision medicine, which means that we isolate the tumor cells from the patients and we screen them against a large library of different therapies. And then the hypothesis is that those therapies that are effective outside of the patient will also be effective in the patient. So I'll focus on hematology, and functional precision medicine is quite advanced in hematology. And last year, there were 2 publications in Cancer Discovery that showed that functional precision medicine is useful to guide treatment for acute leukemia and lymphoma.
Sigrid, if I
Yes.
can interrupt, the mode that we're seeing is not presenter mode, and we're just seeing the
Oh.
edit mode of just your very first slide. I don't know if you may need to swap your screens, or perhaps you have 2 versions of your PowerPoint presentation open.
I have 2 screens. Maybe I can try to disconnect from one of them. Did I try to stop? Did this help?
That is, whatever you just did works. So now
Yeah,
we're seeing
okay.
now we're seeing presenter mode, a slide that says functional precision hematology.
Great. Then I'll do it on this
Great.
screen. Okay. So these maybe did you miss everything then? Well,
Yeah, we didn't see any of the slides that preceded
yeah.
this.
Okay, it was not it was the introduction, so you should anyway. So these are the 2 studies I then referred to that were published last year in Cancer Discovery. Okay, so in the first study, they focused on aggressive acute leukemia and lymphoma. And here they isolated patient samples from bone marrow, lymph node, or peripheral blood. And these samples were then exposed to a library of different targeted therapies. And since the cells will contain both normal and malignant cells, they stained the tumor cells with specific markers so that they could look at the effects specifically in the tumor. And then the treatment efficacies were scored from high to low, and this information was then provided to a tumor board that recommended the treatment for the patients. So in this study, which is a clinical trial called EXALT, 143 patients were enrolled. And out of these, 56 patients, which means 39%, could receive a treatment based on this drug sensitivity testing. And of these, again, 30 patients obtained a clinical benefit. And this corresponds to 54% of the treated patients and about 20% of the total number of patients that were enrolled in the study. The second study focused on acute myeloid leukemia. So the principle is the same, that the tumors were isolated from the patients, and they performed drug sensitivity testing, this time with the cell titer glow assay. And in addition, they did exome and RNA sequencing. And these data from each patient were integrated and then provided to the tumor functional precision medicine tumor board, which gave a therapy recommendation. In addition, these data sets were integrated across all patients and used for translational research. And this way they could identify biomarker subgroups and also provide the reference data that could further improve the decisions that were given by the tumor board. And in this study, 186 AML patients were included, and actionable drugs were identified for 97% of the patients, which means almost all of them. However, in many cases, the therapies were not available, so the recommendations were clinically implemented in 37 only, which is 20%. And of these patients, 59 obtained an objective response rate, and this corresponds to about 12% of the total number of patients that were enrolled. So even if there is room for improvement, these studies demonstrate that functional precision medicine can be valuable for guiding treatment of acute leukemia and lymphoma. Now, if we look at blood cancers in general, we have 3 different main types: myeloma, lymphoma, and leukemia. And these can again be classified into different subgroups. And in leukemia, we have both acute and chronic leukemias, and they are either lymphocytic or myeloid. And this says something about what cell types the cancer arises from. So we have the blood stem cell, and this can become either a myeloid stem cell or a lymphoid stem cell. And then these become further specialized cells, white blood cells, platelets, or red blood cells. So functional precision medicine is most advanced for the acute leukemias, as I just showed you with the two studies. And this is reasonable since the treatment need is most or highest for these diseases. When it comes to chronic myeloid leukemia, I would say that genomic precision medicine has been successful with the identification of the Philadelphia chromosome and BCR-ABL and the treatment with Gleevec. So then what about chronic lymphocytic leukemia? So this is an illustration from work from Torsten Sense's lab, which is one of the pioneers of drug sensitivity testing on CLL. So this is a paper that was published 5 years ago, and here they show that they could do high throughput drug sensitivity screening of CLL cells. And they also combine this with other omics approaches and use this to determine molecular characteristics of drug responses, to do functional classification of the disease, and also look at pathway activity. So this has been really pioneering work that has provided much information about the disease, but it has not yet led to the translation of functional and precision medicine. So our aim is to translate this to develop functional tests to actually guide precision medicine in CLL. So one challenge with the CLL cells is that when you take them from the patient and you try to grow them in the lab, they will undergo rapid spontaneous apoptosis very fast. So we had to develop a protocol where we could maintain the survival of the CLL cells in culture. So the system that we ended up with was one that we consider quite simple, and it's compatible with drug sensitivity testing. So we try to mimic the tumor microenvironment by culturing the CLL cells with fibroblasts that express ligands that the cells are normally exposed to in their natural tumor microenvironment. These are APRIL, BAFF, and CD40 ligand. And after 24 hours, we can separate the cells by pouring off the cell medium, which will then contain the soluble CLL cells, while the fibroblast will still be attached to the culture flask. And this is important because we only want to look at the drug effects of the CLL cells and not have any noise from the fibroblasts. And by doing this, we have shown that the CLL cells survive in culture. So I remind you that the drug sensitivity screens are performed with 3 days of drug exposure. So we needed to have them alive at least for 3 days. So in blue, we see the CLL cells that have been cultured with control fibroblasts that do not express any ligands. And then we see that already after 1 day in culture, less than 40% of the CLL cells are viable. While for CLL cells that have been exposed to these ligands, we see that the viability is still good after 4 to 5 days. And we could further prolong this viability if we did a second stimulation with these ligands at day 4. Then we had 70% viability of the CLL cells after 13 days in culture. But this is already good enough for the assays that we are doing. And we could also see that there was some expression of the proliferation marker Ki67 in the cells that had been stimulated with APRIL, BAFF, and CD40 ligand, but not in the control CLL cells. And we also know from the literature that these microenvironment factors contribute to drug resistance. So this is, of course, relevant when we want to try to look for treatments that are effective in the patients. We want the model to mimic the in vivo situation as much as possible. So then we wanted to see if we also saw drug resistance in these cells that had been stimulated. So here we tested the response to the BCL2 antagonist venetoclax, and on the y-axis you see the relative cell viability, and on the x-axis is the increase in concentration of venetoclax. So in agreement with literature, we see that those cells that have not received the microenvironment stimuli, they are much more sensitive to venetoclax than those that have been stimulated. So with this, we have developed a protocol for culturing CLL cells that provide survival of the CLL cells and which is compatible with drug sensitivity screens. So then I would like to present the first patient case of CLL. This is an older male patient, and he had poor prognostic markers, unmutated IGVH and TP53 mutation. And the timeline here shows the years since diagnosis. So for CLL, it's recommended to not start treatment until the disease becomes symptomatic. So in this case, he didn't need treatment until after 2.5 years from diagnosis. And then it was first attempted to treat with targeted therapies, ibrutinib and idelalisib, but unfortunately, he didn't tolerate either of them. And then he was treated with an antibody, alemtuzumab, and the disease was stabilized. But then when it progressed again, he needed treatment. And at this time, he received the BCL2 antagonist venetoclax. And luckily, this was working well. So after less than a year, the treatment could be stopped because then he had complete response and undetectable minimal residual disease. And he could be off therapy for a bit more than 2 years, but then the disease progressed again. And unfortunately, retreatment with venetoclax did not work this time. So then we have used all the available treatments or approved treatments for CLL in Norway, and the question was what to do next. So we wanted to use this case to test our system of drug sensitivity testing. So this first gave an opportunity to test if we could see the response that we observed in the patient. So we had 2 different samples collected, one before he had received venetoclax and one when he had become resistant to venetoclax. So then we tested the cells against venetoclax ex vivo. And we could see that those cells that were collected before treatment with venetoclax were responding to this therapy ex vivo, while the cells that were collected upon resistance to venetoclax were much less sensitive. And I emphasize that this high concentration here is not clinically relevant because it's much higher than the peak plasma concentration that can be achieved in the patient. So now we have confirmed that our system can mimic the sensitivity that is observed in the patient. So then we did the full drug screen on these cells with a drug library of about, I think, 80 single agents and similar number of drug combinations. And what we saw that was that the cells were very sensitive to proteasome inhibitors. So shown here is the sensitivity to ixazomib. So this drug is not approved for CLL, but it's used to treat myeloma. So then it was decided to try this as a therapy for the patient. And it was nice to see that he obtained a partial response to the treatment. So this is shown here with the blood and bone marrow smears. So this is the sample collected when the patient was progressing and resistant to venetoclax, while T7 is a sample collected during treatment with the proteasome inhibitor. And the brown staining here shows the CLL cells, and we saw that it was reduced from 90% here of the bone marrow to 65% here. So this patient was on or responding to the treatment for 6 months, but then unfortunately the disease progressed again and he passed away. But this case shows in principle that drug sensitivity testing can guide treatment decisions in CLL. So CLL is the most common form of leukemia in Western countries, and it mainly affects the elderly people with the diagnosis of median time of diagnosis at 72 years. And for a long time, there were very few treatment alternatives. So in the 1980s, we had the chemotherapy, and this was the only treatment option for several decades. And in 2010, anti-CD20 antibody was added, And this chemoimmunotherapy is still being used today, although less frequently than before. And in 2004, the real change happened when targeted therapies were approved for CLL. And there are 3 classes of targeted therapies approved for CLL, BTK inhibitors, PI3 kinase inhibitors, and the BCL2 antagonist venetoclax. And the first-in-class BTK inhibitor was ibrutinib. And this has been really good for the patients and really changed the management of the disease. But unfortunately, like for all cancer therapies, resistance and intolerance is a challenge. Now that we have almost a decade of experience with ibrutinib, we know more about the resistance mechanisms. And one known resistance mechanism is that the BTK, the target of ibrutinib, is mutated. But this only explains a fraction of the resistance cases. So we wanted to study other resistance mechanisms to ibrutinib. And here we have developed a murine CLL model for ibrutinib resistance. So this study was a collaboration with Martina Seifert at the German Cancer Research Center. She led the study and we made a small contribution. So here is the design for how the mice were made. So the mice were transplanted with CLL cells. And we had 2 groups. So one was treated with the control vehicle, and the other group was treated with ibrutinib. And then the tumor load in the blood was assessed over several weeks. So for the mice that were treated with the vehicle, we see that the tumor load increases quite rapidly. And at 3 weeks, the mice had to be sacrificed. But in blue, we have the mice treated with ibrutinib, and then we see that the CLL cells are nicely stabilized, and they did not start to grow until after 4 weeks. And then they increased rapidly, and the mice had to be sacrificed at 6 weeks. So this shows that at this stage, the cells are resistant to ibrutinib. And this was confirmed by a second treatment round. So here the cells from the vehicle-treated mice are transplanted into new groups of mice, where one group is again treated with vehicle, and the second group is treated with ibrutinib. And since these cells had not been exposed to ibrutinib previously, they were first responding to the treatment, but again, they developed resistance and they had to be sacrificed. While the mice from the ibrutinib-resistant, the CLL cells from the ibrutinib-resistant mice, they did not respond to ibrutinib in the new mice. So now we have a model for ibrutinib resistance, and we could collect samples from these mice at different time points. So an early time point, both from the vehicle group and the ibrutinib group, and then a late time point from the vehicle group and from the ibrutinib group, which means at ibrutinib resistance. And then different assays were performed on these samples: whole exome sequencing, RNA sequencing, and mass spec. And I'll show you the data on the RNA sequencing. So this is shown here. We have the 4 different groups of mice, and we had 3 to 4 mice in each group. So first here in pink and purple, you see the early time points from the vehicle and the ibrutinib treated mice, which look quite similar when you look at the RNA transcripts. And then we have the late time from the vehicle mice. So that's when the disease progresses, and we start to see some changes here. But the biggest change is in the ibrutinib resistant situation here, where we have really clear differences from the other groups. So then when we did the gene ontology analysis, we could see what kind of genes these transcripts represented. And almost on the top came proteasome genes. And I remind you that the case I presented was a patient that was treated with a proteasome inhibitor. So that was quite interesting. So then we decided to test the proteasome inhibitor in these mice. So the scheme is shown here. So again, we have the same mice, control or ibrutinib resistant. and they are treated either with the vehicle or with the proteasome inhibitor carfilzomib. And shown here is the CLL cells in the blood. And these are from the ibrutinib naive mice. So we see that when they are treated with the vehicle, the cancer cells progress. And when they are treated with carfilzomib, we also see a small increase, but really much slower than in the control group. So these are in the naive mice. Now, these are in the ibrutinib resistant mice. Again, we see that the tumor load increases, but it's much more rapid in the vehicle-treated mice than in the mice treated with carfilzomib, suggesting that carfilzomib is able to control disease also in the resistant setting. And we also tested this on primary CLL cells from patients. So here we have samples from 3 treatment-naive patients and 1 sample from a patient who was resistant to ibrutinib. And we did the drug testing with 3 different proteasome inhibitors, and we see that they respond very similarly. So carfilzomib is able to inhibit cell viability also in ibrutinib-resistant CLL cells. So this indicates that maybe proteasome inhibitors can be a treatment option for BTK inhibitor-resistant CLL. And based on these findings and our experience with the patient case, we are now opening a CLL cohort in the precision medicine trial in Norway called IMPRESS Norway. This is a prospective non-randomized trial, and it's a pan-cancer trial, but we will open a cohort on CLL. And the idea about the trial is that we have to have a biomarker that guides precision medicine. So in our case, that will be drug sensitivity testing. And this is just to show the design of the trial. So the target needs to be defined in advance. So therefore, we decided to have sensitivity to the proteasome inhibitor as a target. And we will do the first stage with including 8 patients. And then if we have at least 1 patient who responds, which means response to therapy for at least 16 weeks, then we can expand to additional 16 patients. And then if at least 5 patients respond, it's possible to expand even further. Now coming back to the different classes of targeted therapies in CLL, the second class is PI3 kinase inhibitors. And here the first approved therapy was idelalisib. And one challenge with PI3 kinase inhibitors is that they show a lot of toxicity. So intolerance to therapy is a challenge. It has been shown for BTK inhibitors that it is possible to treat patients with a different BTK inhibitor in cases where intolerance occur. So we were interested to see if this is also something that could be tested in idelalisib intolerant or refractory patients. So we wanted to do a study on 10 different PI3 kinase inhibitors. And I know that this is small and you don't need to see everything that is here, but it's to illustrate the target specificity and activity of the 10 inhibitors that we included in the study. So when I say PI3 kinase, I mean class 1 PI3 kinase, and the catalytic protein P110 exists in 4 different isoforms: alpha, beta, gamma, and delta. And some of the inhibitors are specific to the delta and gamma isoforms, which are more expressed in leukocytes, while other inhibitors target all 4 isoforms. And I will refer to those as pan inhibitors. So idelalisib is the isoform-specific inhibitor. It mainly targets P110 delta, while, for example, copanlisib, which is approved for other lymphomas, target all 4 isoforms, and it's therefore I call it a pan inhibitor. So first, we wanted to look at the sensitivity to these different PI3 kinase inhibitors in the cell line model of idelalisib resistance. So this is a lymphoma cell line, Karpas 1718, and we had the parent version of the cell line and the cell line that had been exposed to idelalisib over time and became resistant. So here I show you the drug sensitivity score, which is a score that says something about the sensitivity to the treatments. It's based on the cell viability curve and the area under the curve. So a higher score means higher sensitivity, and the maximum score is 100. So we first saw that the sensitivity to idelalisib was very low to start with, but at least we do not see, or we see less sensitivity in the resistant cell line. And the second observation was that the PAN inhibitors were most effective. So in the black, you have the parent cell line, and in blue, you have the resistant cell line. And we see that even though the sensitivity is reduced upon resistance, there is still some sensitivity. And then we looked at the primary CLL cells from either treatment-naive CLL patients or patients that were either refractory or intolerant to idelalisib. And again, this is maybe not the best assay to monitor sensitivity to idelalisib, but at least we saw that there was a higher sensitivity in the treatment-naive cells than in the refractory cells. And then when we compared to the sensitivity to copanlisib, we saw a clear difference. And here also we use 10-fold lower concentrations because copanlisib is known to be more potent than the other inhibitors. And here we saw that copanlisib was very effective, both in the treatment-naive cells and in the idelalisib exposed cells. And it's common to not treat with single agents, but to use combinations to get better responses and try to prevent resistance. So we wanted to study the effect of combining these PI3 kinase inhibitors with venetoclax, which is used in many different combinations in clinical trials. So here we again looked at the induction of apoptosis by measuring cleaved caspase 3 by flow cytometry. And here is the response to increasing drug concentrations. So as expected, and just to make sure clear that we only exposed in these experiments for 30 minutes, so very short. But we could still see that venetoclax was able to induce apoptosis in the cells, while the PI3 kinase inhibitors could not induce apoptosis after only 30 minutes. However, we still saw an additive effect when we combined a PI3 kinase inhibitor with venetoclax, suggesting that there is synergy between these agents. And we also saw that the CLL cells, again from the treatment-naive patients or patients that were refractory or intolerant to CLL, were sensitive to these combinations, as shown here for idelalisib plus venetoclax. So CLL cells from idelalisib refractory or intolerant patients, they remain sensitive to other PI3 kinase inhibitors and PI3 kinase inhibitor plus venetoclax combinations. So then I would like to present a second patient case, and this is a female patient who also presented with poor prognostic markers, unmutated IGVH and TP53 mutation. So again, we see the timeline here in years since diagnosis. And she first received treatment with chemoimmunotherapy and obtained a complete response. She could then be off therapy for several years. And when the disease came back, then retreatment with chemotherapy was tried, but there was no response. And at this time, luckily, the targeted therapies were available. So then she was started on the BTK inhibitor ibrutinib. And this was effective for a few years, but then the disease progressed. So then we wanted to do some analysis on her CLL cells. And we had one patient sample collected here at time 0. So then we first wanted to see if we could see also ex vivo the resistance to ibrutinib. So the cells were treated with this drug, and we looked at the phosphorylation of the target of ibrutinib, BTK, by flow cytometry and in response to increasing concentration of the drug. And we see that ibrutinib is not able to inhibit BTK phosphorylation in these cells that are resistant to ibrutinib. And this line here, it indicates the plasma concentration that can be achieved with ibrutinib. So these two highest concentrations, they are not clinically relevant. And then we wanted to do the same with other targeted therapies to look at the response in the CLL cells. So we tested the sensitivity to idelalisib by looking at the downstream effector of PI3 kinase, AKT. And here we see that there is a nice inhibition of AKT. So the cells are clearly responding to idelalisib. And similarly for venetoclax, here we used cleave caspase-3 as a readout. And we see that they nicely respond. They start to undergo apoptosis with the increase in concentration. So then first, following ibrutinib resistance, the patient was treated with idelalisib, but unfortunately she did not tolerate it, and the therapy had to be stopped after 3 months. And then the therapy was changed to venetoclax, and she had a response, but then the disease progressed after almost a year. And now we are in the same situation as for the previous patient case, that all the therapies that are approved for CLL in Norway had been used, and the question is what to do next. So then we collected a patient sample here at time 1, and we could do a drug sensitivity screen. And of the drugs that we tested in our drug library, we found that the cells remained sensitive to PI3 kinase inhibitors plus venetoclax, as indicated here. And then it was decided to try treatment with idelalisib plus venetoclax because these therapies are available. Sorry, I need to drink a bit. These therapies are available in Norway. And she obtained a partial response, but unfortunately she again had adverse effects and the therapy had to be stopped. So this is illustrated here, and the last gray bar here shows the combination therapy, and it only lasted for 2 to 3 months. But we still wanted to look at the evolution of the disease and see if we could learn something about the disease from this case. So we also collected the patient sample during the treatment with the combination, just after treatment stop, and then 5 months later. And we performed the protein profiling by flow cytometry. So here we have looked at these 30-something proteins by flow cytometry at the 5 different time points. And we could see some clear differences in this phenotype. So one example is illustrated here, where we looked at BTK phosphorylation. So we could see that while the patient was on combination treatment and responding to the treatment, the BTK phosphorylation was reduced. And just after end of treatment, the signaling was still low. But then upon progression, we see that the signaling really increased. And this was also reflected in other PCR signaling proteins. And then we also did the drug sensitivity screen on the patient samples. And here I show you the response to BTK inhibitor plus venetoclax. And interestingly, we saw that the sensitivity was reasonably low when the patient was on venetoclax-based therapy. But then when the disease progressed again, the sensitivity also increased. And this pattern is similar to what we saw for the BTK phosphorylation. So this is something that will be interesting to follow up. Unfortunately, we could not test these therapies in the patient because she was too sick to receive treatment. So this shows that functional testing could identify treatment vulnerabilities in this patient case, but we were not able to predict tolerability. And we are trying to see if that would be possible with functional testing. So here are just some examples of other predictions we have been able to do based on functional tests. So these are a few patient cases, 3 in each group, and that were they were treated with PI3 kinase inhibitor idelalisib, but these samples were collected before they received the treatment. But then we knew the outcome. So these patients responded shortly, meaning that they became resistant to therapy, while these patients had a long response to the treatment. So we performed the drug sensitivity screen with 73 drug combinations. So each dot represents the sensitivity to one drug combination. And on the axis, we have the drug sensitivity score. So a higher score means higher response to the treatment. So if the treatment was the same in the short term and the long term responders to adalimumab, then all these dots should fall on this diagonal line, which we see that they do not. They are more skewed towards the right here, showing that overall the sensitivity is higher in those cells that come from the patients that have a good response to adalimumab. We also did a study on a second cohort of CLL patients. These are from a trial of patients that received treatment with another PI3 kinase inhibitor, umbralisib. So these samples were also collected before the patients received treatment on the trial. And here we did protein profiling, like I showed you on an earlier slide. So we looked at the expression or phosphorylation of 32 proteins. And then we tried to see if we could use these data to predict the outcome on the trial. So some of the patients received or obtained a partial response to the treatment, and some patients obtained a stable disease. And here we tried to predict the probability of the patient obtaining a partial response. And if the probability is higher than 0.5, then the model predicts a partial response. And we see that the model correctly predicts this for the patients that obtain the partial response, and correctly predicts that the patients will not obtain a partial response for the patients that obtain the stable disease. So this shows that functional testing can stratify responders to the PI3 kinase inhibitors, adalimumab and umbralisib in CLL. And then I'll just briefly mention that we are also trying to do some work on patients who receive venetoclax-based treatment regimens. So we have not come so far yet, but this is just to illustrate where we are going. So here we are studying patients that have been enrolled in clinical trials. So first trial we are studying is the Vision HOVON 141 trial. It's a phase 2 study of ibrutinib plus venetoclax, and in total 230 patients were enrolled. And the second clinical trial that we are studying is the Gaia CLL 13 trial, which is a phase 3 study with 4 different treatment arms. So the patients, this is the first line of therapy, so they either receive a chemoimmunotherapy or 3 different time-limited treatments with venetoclax and different CD20 antibody and addition of ibrutinib in the 4th arm. And this is a very big trial with 900 patients enrolled. And this work is a collaboration that we are doing in this EU-funded project CLL Clue, where we are 6 partners in Europe, as indicated here on the bottom of the slide. And the idea of this project is to study CLL patients that have been enrolled in clinical trials and to collect different types of data from them. So both clinical data, genomics data, and functional data, as I have shown you here. And then we want to integrate all these data sets to make, hopefully, models that can predict treatment outcomes, such as MRD status, infection progression, and so on. So our overall aim is to tailor the targeted treatment of CLL patients. And with that, I would like to thank everyone who has been involved in these studies, and of course the patients who contribute to our research and our funding resources.
Great. Thank you very much, Sigrid. That's a great update on what you're doing in Norway. Well, I think probably though, usually what happens is a few questions will roll into the chat. I want to ask a question. I wanted to go back to you mentioned the IMPRESS clinical trial. Now, from what I saw you present, that's actually a trial, like an umbrella trial, where patients are being assigned therapies based on molecular rather than functional data. Is that accurate?
Yes, so far they are only enrolling based on genomic mutations, but the idea is to expand to also include other types of biomarkers. And then for the CLL cohort, it will be drug testing that is the biomarker.
Okay. Now, do you see, like, I know what I often think about is a lot of what we need to do as a field is like convincing people that it works before we try it. So do I understand correctly? Like you mentioned the Vision trial, the Gaia trial, you mentioned the Impress trial. Even before assigning patients treatment, are you collecting samples and testing your ability to predict in arms where they're assigned by other means? Are you testing your ability to discriminate responders and non-responders in those arms?
Well, that's what we hope to do based on the patient samples from those two last trials I mentioned, the Vision trial and the Gaia trial.
Okay,
So then
great.
we'll screen all the patient samples from baseline and then see if we can find predictors of treatment outcome on the trial.
Okay, great. Yeah,
Yeah.
I think that's
We're
right.
just taking different approaches simultaneously, let's say.
That's great. Could I'll turn to the chat now. If you're Jun Yang, I think you're still here. Maybe you could ask your question.
Sure. Great talk. I just have a, can you hear me?
Yep.
Okay, I just have a quick question. I'm not sure if I understood the data correctly. I think you have one slide where you show the correlation plots. There's a line of identity and you're comparing short responder versus long-term responder. And it's for combination, drug combination. And it seems like most of the dots are at the lower left corner of the plot. Does that mean that most of the combination didn't really have very strong effects ex vivo?
Yeah, I think what we saw was that the sensitivity was at least lower in the short-term responders. For the long, we saw that they were maybe low on the y-axis, but higher on the x-axis. So high drug use sensitivity. But yes, in general, we see many treatments that are not very effective ex vivo, which is expected, I guess.
I mean, generally speaking, I think whether it's long-term responder or short-term responder, most of the dots are in that corner. Seems to suggest that the response was not super robust in ex
but
vivo.
it is. I think we also need to understand better what is the cutoff to say it's a good response, how this correlates with the in vivo response, because as I also show you that we're not able to get a very nice response to PI3 kinase inhibitor ex vivo, even if we know that it's working in the patient. So maybe it's assay dependent. So we know that PI3 kinase inhibitors, they inhibit proliferation and the CLL cells do not really proliferate ex vivo. So we have to be a little bit careful to directly compare the different classes of drugs in the same assay, I think.
Thank you.
Thanks, Keith. Keith Ligon, do you want to ask your question?
Yeah, so that was a great talk. I just wanted to know whether you'd been able to use the function to kind of determine maybe prognostic factors like P53 combined with MDM2 inhibitor is potentially a good way to have a really nice quick test to tell if they're functionally intact for P53 or not, or have you explored other correlations with biomarkers for prognosis?
Yeah, we had a small study in multiple myeloma where we tried to look at the correlation between genetic markers like TP53 mutation and drug sensitivity, and we saw that there was a correlation between these markers as well. But in the same study, we also looked at protein expression, like the protein profiling that I showed you for CLL, and we also see nice correlation between protein expression, which of course, in this audience here, I think it's also interesting that it's not only correlation with the genetic mutations.
We found something similar, yeah. Totally different systems. Matt Davids.
Hey, Sigrid, really exciting work. Great job. This is a question I frequently get, so I'll put it to you because I do think it's relevant sort of where the sample is derived from. And most of the patient samples you were discussing were from peripheral blood. Is that correct? And if so, do you think there would be some differences if you took samples from lymph nodes and bone marrow? And then, if there are differences, how do we then translate that into a clinical test where we might not have lymph node or bone marrow samples from the patients?
Yeah, so of course we would like to make this system as easy and as available as possible. So I think if we can make it work on peripheral blood and show that the data are predictable of the response in the patients, that's the aim of the whole thing. So then it's not so important if we see differences in cells that come from from lymph node or bone marrow, I think.
Thanks.
Yeah.
So if I understand, so I'll just, maybe one last question. If I understood correctly, so I have a lot of the drugs we study, I mean, we do a lot of work on venetoclax, so forth. And very often when we look into mechanisms of resistance to venetoclax, perhaps not surprisingly, there's often changes in programmed cell death wiring. It seemed in your study of BTK inhibitors, however, that there's actually way upstream an effect on simply the ability to inhibit actual enzymatic BTK function, way upstream of cell death effects. Have you ever looked, you looked across PI3K inhibitors to see, and you showed that there's differential response in when you have like an idelalisib resistant clone. Did you look at other drugs of totally different mechanism to see if there's a broad pan resistance in those CLL samples?
We have the data, but I haven't addressed this question, but that's something I could look into.
Okay, great. Okay, everyone. Sigrid, thanks again for a great talk and a great update of what you guys are doing up there in Norway. I see it's already quite dark there, so I really appreciate you joining us at this relatively late hour for you. Everyone, hopefully you will join us again in February. A little bit of a teaser, I think I provided before. We're going to be having a reception on the Monday of AACR. I hope everyone, Monday evening of AACR coming up in April, and then Tuesday there will be a there will be a functional precision medicine symposium as part of the AACR meeting, and I hope all of you who are coming to Orlando for that will attend both events. So nice to see you all again. Happy New Year, and see you in February.
Thank you.